Ladies and gentlemen, welcome to the opening of STI and HIV World Congress 2017. This Congress represents the joint biennial meeting of IISTDR and the annual IUSTI World Congress in partnership with the local organizer, the Brazilian Society of Sexually Transmitted Diseases, BSSTD, Rio de Janeiro. Welcome. This Congress is unique and brings together the most preeminent researchers in the field of sexually transmitted infections, including HIV, to present new work. Within this Congress, we will hear the latest interpretations of new data from the world experts and discuss the implications of these findings for health policy and delivery of patient care. I would like to announce and welcome the chairs of STI and HIV World Congress 2017 and also invite them to take a seat. Dr. Jeanne Marrazzo. Dr. Jeanne Marrazzo is Professor of Medicine and Director of the Division of Infectious Diseases at the University of Alabama, Birmingham. She's internationally recognized for the research and education efforts in the field of sexually transmitted infections, especially as they affect women's health. She is a fellow of the American College of Physicians and of the Infectious Diseases Society of America. Dr. Marrazzo is also the chair of the American Board International Medicine Council and also chairs the ABIM Infection Disease Specialty Board. She is the board certified of the infection disease. She conducts research on the human microbiome, especially as it relates to female reproductive tract infections and hormonal contraception. Her other research interests include the prevention of HIV infection using biomedical interventions, including microbicides. Recently, Dr. Marrazzo led the VOICE study, a large study evaluating HIV pre-exposure prophylaxis administered vaginally and orally to women at high risk for HIV infection in Sub-Saharan Africa, conducted by the National Institute of Health-funded Microbicide Trials Network. Other areas of research interest include pathogenesis and management of bacterial vaginosis, sexually transmitted disease and HIV infection persons, and management of antibiotic resistant in gonorrhea. I would like you to invite to take a seat Dr. David Lewis. Dr. David Lewis is director of the Western Sydney Sexual Health Center. He is Professor Mary Besher Institute for Infectious Disease and Biosecurity of the University of Sydney, and he's also the president of the International Union Against Sexually Transmitted Infections. I would like to invite to take a seat Dr. Mauro Romero Passos. Dr. Romero is the president of the OB-GYN Society in Rio de Janeiro, and he's also the chair of the STI and HIV World Congress, Rio. He's a full professor of the section of STD of University of Federal Fluminense. He's the president of the Brazilian Society of Sexually Transmitted Diseases. Now we are going to hear the national anthem.
raios fúlgidos brilham no céu da pátria nesse instante. Se o penhor dessa igualdade conseguimos conquistar com braço forte, em teu seio, ó liberdade, desafia o nosso peito a própria morte. A pátria amada, idolatrada, salve, salve, Brasil, um sonho intenso, raio vívido, de amor e de esperança a terra desce. Sem teu formoso céu risonho e límpido, a imagem do cruzeiro resplandece. Gigante pela própria natureza, estrelas forte pálido colosso, e o teu futuro espelha essa grandeza. Terra dourada, entre outras vilas do Brasil, a pátria amada, dos filhos deste sol és mais gentil, pátria amada Brasil. Deitado eternamente em berço esplêndido, ao som do mar e à luz do céu profundo, fulguras o Brasil, florão da América, iluminado ao sol do novo mundo. Do que a terra mais ardida, teus risonhos lindos campos têm mais flores, nossos bosques têm mais vida, nossa vida no teu seio mais amor. A pátria amada, idolatrada, salve, salve, Brasil de amor eterno seja símbolo, lá para o teu sentas estrelado, e diga o verde louro desta flor, mas no futuro e glória do passado, nas sedes da justiça clava forte, verás que o vinho teu não foge à luta, nem teme quem te adora a própria morte. Terra dourada, entre outras vilas do Brasil, a pátria amada, os filhos deste sol és mais gentil, pátria amada Brasil.
Um cantinho, um violão, esse amor, uma canção pra fazer feliz a quem se ama. Muita calma pra pensar e ter tempo pra sonhar. Da janela vê-se o Corcovado Redentor. Que lindo, quero a vida sempre assim, com você perto de mim, até o apagar da velha chama. E eu que era triste, descrente desse mundo, ao encontrar você eu conheci o que é felicidade, meu amor. Um cantinho, violão, esse amor, uma canção pra fazer feliz a quem se ama. Muita calma pra pensar e ter tempo pra sonhar. Da janela vê-se o Corcovado Redentor. Que lindo, quero a vida sempre assim, com você perto de mim, até o apagar da velha chama. E eu que era triste, descrente desse mundo, ao encontrar você eu conheci o que é felicidade. felicidade? O que é felicidade? O que é felicidade, meu amor? Meu amor.
The worries of the environment has to make part of all of our actions, including all events, considering the damages provoked by the climate changes occurrence in the planet's STI and HIV even has taken the commitment to compensate the production of emissions of greenhouse gases effect. This Congress, in partnership with PRIMA Institution, has followed methodologies defined by the national and international regulatory organizations, which are ABNT, NBR, ISO 14064, GAG Protocol, and IPCC guidelines. Traveling of all participants, local transfer, accommodation period, energy, and organic waste were calculated. To effective environment compensations, M6 and 695 Atlantic Forest tree were planted in the public area of the Federal University of Rio de Janeiro campus Pinheiral. Some direct benefits are forest formations, soil restriction, degraded area recovery, and regularization of the water cycle. The STI and HIV World Congress at this moment received the PRIMA carbon-free certificates. Congratulations all participants who collaborated to build a low-carbon society. I would like to call Dr. Ricardo to give the certificates to the President. Dr. Ricardo represents the PRIMA institution. I would like to show the slides of the Carbon Zero presentation to you all. So this is the Carbono Zero, some images of the project. That was December 2016, the project Carbono Zero. There are some images.
Yes.
That's great. As you can see. And the field that represents the project also. Okay, so I would like now to invite Dr. Mauro, our president, to the speech. Please, Dr. Mauro.
Okay. Before we begin, we should recognize and honor a person which is a pure expression of intelligence, tolerance, friendship, efficacy, collaboration, and fighter. She is the scientific director of the STD Brazilian Society, Espírito Santo's Associate Federal University Professor. Please, Angelica Espinosa Miranda, please come over. Come over here and accept this certificate of merit and our most gratitude. Fica aqui. Fica aqui. Caroline Cameron, please. Come over. You is the same for the Angelica Cameron. Okay. Please. For you, for Jeanne, and for okay? The same. Okay. Okay, for you. Okay. Friend, we had many bumps, but we are here for one more edition of STI in the HIV World Congress, now Rio de Janeiro. Boa noite. Good evening for all. In the 70s, still a medicine student, please, slide please, I bought this poster. I identify with the message immediately. Since very early in my medical life, a family father, family friend, and have this attitude. Where are number, percentage, injury, money, power, status, reagent, non-reagent, positive, negative, I try to see and value people. In 1981, a month prior to my graduation as a doctor with only $460 American dollar in my pocket without credit card, I traveled for the first time abroad without hotel reservation or a Congress registration. I met a few Brazilian doctors, won the journal, and split the room with two of them. Antônio Gerbasi is one of them and is at this event. Professor Walter Belda from São Paulo University and Corinto Santos from Goiânia, they looked after me as I was their son. After that, I went to other STD World Congress, Paris 1986, Amsterdam 1992, on that we collaborated with the scientific committees, and until today, I keep the thank you letter received by the dear Professor Jonathan Mann. We did many meetings, always with the collaborative participation of many. You have no idea how many have collaborated. Moreover, continues doing it. Without this friend from Federal Fluminense University, Brazilian Society, and the STD, and another society, never would be possible to be in Rio. 21 years ago, it was a beginning of STD and AIDS Congress, all with many participants. We decided them have the audacity to go to Vienna, Angelica, to Vienna, in 2013, and submit the RIO candidates, Brazil, to host here one that is one of the best scientific congress in the world about STI and HIV. We like to thank all the sponsorship and the collaboration, especially our dear Fluminense Federal University, our academy support, STIs Department, and AIDS and Hepatitis Health Ministry. We thank to excellent secretary and the beautiful girls from Rivera Rio and Activia. To recognize and thank you the president and colleagues of ISSTDA and IUSTI, Jeanne and David, for their patience, tolerance, and wisdom. Thank you, colleagues, and the members from all the scientific committees. Thank you a lot. Thank you a lot. Thank you, our colleagues and friends from the Brazilian Society of STD and the Federal Fluminense University, who always have given us their trust. I would like to thank my family, my wife, Renata, and my 5 children, Mariana, Felipe, Paula, Carolina, and Gabriel, who won't give up on me. Finally, in scientific committees, in scientific events, each one of us likes to present the best diagnostic, treatment, scientific evidence with meaningful tests with the most modern and efficient in many different ways. But is not what not to do. And for us, it is very important. What not to do. We need the reflection. Muito obrigado a todos. Espero que tenham uma boa noite e um grande evento.
Olha que coisa mais linda, mais cheia de graça. Ela é a menina que vem que passa num doce balanço a caminho do mar. Oh, moça do corpo dourado, do sol de Ipanema, o seu balançado é mais que um poema, é a coisa mais linda que eu já vi passar. Ah, porque estou tão sozinho. Ah, porque tudo é tão triste. Ah, a beleza que existe, a beleza que não é só minha, que também passa sozinha. Ah, se ela soubesse que quando ela passa, o mundo inteirinho se enche de graça e fica mais lindo por causa do amor. Olha que coisa mais linda, mais cheia de graça. Ela a menina que vem e que passa num doce balanço a caminho do... Moça do corpo dourado, do sol de Ipanema, o seu balançado é mais que um poema, é a coisa mais linda que eu já vi passar. Ah, porque estou tão sozinho. Ah, porque tudo é tão triste. Ah, a beleza que existe, a beleza que não é só minha, que também passa sozinha. Ah, se ela soubesse que quando ela passa, o mundo inteirinho se enche de graça e fica mais lindo por causa do amor, por causa do amor, por causa do amor, por causa do amor.
Now, I'd like to invite Dr. Jeanne Marrazzo to talk. Thank you, Samantha. I'll try to help you. Okay, excellent. Thank you. I've spoken in many stressful situations, but I never thought I would have to succeed the girl from Ipanema. It's a real pleasure to be here, a tremendous pleasure to welcome everyone to this meeting. I've heard a number of people reminiscing about prior ISSTDRs over the last several days, and so many people have told me that this is the conference that they have loved presenting their work at since they were really young people in training. So really special, I think, to be here. The other thing I want to say is that this meeting in particular represents a very special commitment. And commitments, as we all know, require a leap of faith, and sometimes they're really scary. And I think the commitment here was to hold this meeting in a place that we had never had this meeting before, the first time in the Southern Hemisphere, in a country that we had not been together at for a meeting, and a commitment to present the best science in the field here. Also a commitment of an incredible scientific organizing committee, who I will call out in a moment, who worked literally tirelessly to put this meeting together, along with the organizing team and everybody that I'll mention. So really want to celebrate the commitment that made it happen, and I think it reflects our commitment to continue to working in a field of sexual health and STDs
despite a lot of odds that continue to mount over the years. So a really, really wonderful opportunity. I will just start off by reciprocating Dr. Mauro's thanks to David and me. It's been a pleasure to work with Dr. Mauro. As you can tell from his slides, his spirit is just beautiful spirit, and his commitment to this field and to the care of people with STIs, in particular in HIV, I think is unparalleled. So let me just say a few words about ISSTDR. As was mentioned, this is the 22nd ISSTDR meeting. Sorry, okay. So I would like to go back. Actually, could I just have the next slide? I don't think this seems to be working. It's also going back. Okay, there we go. So as I mentioned, the scientific committee was chaired by the two women that you saw previously, Dr. Angelica Espinosa Miranda from Brazil and Dr. Caroline Cameron from the University of Victoria in Canada. And I'd like to give them another round of applause because they really did an amazing job putting this meeting together. The scientific tracks are going to be shown on the next slide. Dr. Magnus Unemo from Sweden led the Systems Biology and Novel Technologies for Molecular Analysis and Diagnosis track, and the team was comprised of Anne Gers from the USA, Jacques Ravel in France, Joanne Passmore in South Africa, Jorgen Jensen in Denmark, Luisa Villa from Brazil, Nicholas Thompson in the UK, and Tony Cunningham in Australia. Really wonderful international representation. Sorry. The clinical science track, ably led by Dr. Bradley Stoner from WashU in the United States, along with Andrew Mujigira from Uganda, Keith Radcliffe in the UK, Laura Bachman, US, Somesh Gupta, India, Suzanne Garland in Australia, Case Rietmeyer from the USA, Freddie Tina Harris from Honduras, and Maria Angela Frias da Silveira from Brazil. So really, again, I just want to emphasize the outstanding international representation on all these tracks. Epidemiology, Monitoring and Evaluation, chaired by Mark Stebbin from Quebec's National Public Health Institute, along with B. Voilstek, Belgium, Bill Miller, USA, Helen Ward, UK, Lisa Manhart, USA, Michelle Allery, Canada, Patricia Garcia, Peru, Philippe Mayod in the UK, and Rebecca Guy from Australia. Really amazing work. And then last, Dr. Seb Guiral chaired the Behavioral and Social Science Research Team with Alain Giamy from France, Catherine Mercer from the USA, Jackie Jennings, also USA, Lisa McDade from Scotland, Megan Lim, Australia, and Sarah Hawkes from the UK. Finally, Chris Farley, or Kit Fairley, biomedical STI HIV prevention, along with Andrew Grulich from Australia, Anna Walden, Jared Baton from the US, Marco Vittoria, Brazil and Switzerland, Sharon Hillier, Sheila Lughart from the USA, and Sheena McCormick from the UK. And really finally, I think, sorry, I forgot there were so many tracks, it just went on and on. Gail Bolin, Policy, Advocacy, and Community Engagement with Adele Schwartz-Benzaken from Brazil, Basil Donovan, Carlos Caceres, Peru, James Chiara from Kenya, Jamie Leichleiter from the US, Jonathan Ross, UK, Lisa Smiley from Canada. So here's what we ended up with the work of those incredible people. This is the scientific program summary. We have a keynote lecture, which you're going to hear tonight, which I'm very much looking forward to, 12 plenaries, 16 symposia, 16 oral presentation sessions, and 4 pre-Congress symposia, as you already know. We received almost 700 abstracts, and these are published in the STI Journal, which was in your welcome packet. We really want to thank our 74 abstract reviewers for their assistance. It was really invaluable, and we would not be having this meeting without them. We also really want to thank the Scholarship Committee. We were fortunate to have resources to bring scholars here, and we'll be letting you know who those are. Bobby Vanderpool chaired the committee. She's from UAB. I was on the committee along with my colleague from UAB, Dr. Ned Hook, Dr. Dennis Fortenberry from Indiana University, Jackie Jennings from Johns Hopkins, and Janet Wilson from the University of Leeds. Really very, very important work to choose from many deserving scholarship applicants. Sorry. We also had scholarship donations from some key sources, including the ISSTDR Foundation, the Kathy Eisen Scholarship, administered through BASH, the NIH, and SPDS IST. And then finally, I will just thank our sponsors again. Although Mauro mentioned them, the meeting would not be possible without the very generous support of our Diamond, Platinum, Gold, and Silver sponsors in particular. So thank you very much. And with that, I just want to remind people that we are very much looking forward to the next ISSTDR-IUST joint meeting, which will occur in Vancouver 2 years from now, from July 14th to 17th. And the Caroline Cameron, who's our scientific co-chair, will be the president of the ISSTDR and leading that meeting. So be sure to put that in your calendar. Sorry, this is a very skittish thing. And I think, and just to remind you, this it puts me a little bit in mind of the views from Rio. It's another beautiful city, so it should be a fantastic venue. And that's the Convention Center, which looks out into the bay there. That's where we'll be, with Stanley Park on the right. So please plan on coming. And with that, I think I'm going to turn it over to David Lewis to take us into the IUST presentation.
I would like to invite now Dr. David Lewis for the talk.
So I'd like to express my thanks to Mauro and the organizing team on behalf of the International Union Against STIs. This is our 18th IUST World Congress. For those of you who are not familiar with what IUST does, just a few words here to explain. First of all, the organization was founded in 1923, which makes it the oldest international organization with the objective of fostering international cooperation in the control of STIs, including HIV and AIDS. USTI is concerned really with the medical, scientific, social, and epidemiological aspects of STIs and their control. The organization is on the roster of the United Nations Economic and Social Council and is an official non-government organization in consultative status with the World Health Organization. IUST organizes many conferences and publishes STI management guidelines and is a registered charity in the United Kingdom. USTI has a very regional approach. We have 5 regions: Europe, Asia Pacific, Africa, North America, and Latin America, where we are celebrating this particular meeting. We support our regions through running World Congresses on an annual basis. And as you can see, in the last 5 years, we visited every one of our 5 regions, starting in Vienna in 2013, North America in Atlanta in 2014, Brisbane in the Asia Pacific region in 2015. Last year we went to Marrakesh, North Africa, Morocco, and this year, of course, we're in the Latin America and the Caribbean region in the beautiful city of Rio de Janeiro. I'd like to just let you know that this continues, this trend of annual meetings, and next year there's going to be the World IUST Congress held in collaboration with the USTI Europe regional branch. That will be held in Dublin in June. Also, our regions run their own congresses, which are not necessarily world congresses, and the last one of those that we had was a beautiful congress in Japan, in Okayama, held in December last year, and the next one's going to be not too far away. This is going to be in Helsinki. This is probably the nicest picture that I've seen advertising a congress. It's very colorful, as you can see. This is end of August to the 2nd of September. USTI has an active membership base, so we have full members who are paid up and therefore have voting rights and some other advantages, for example, reduced subscription for International Journal of STD and AIDS. Also, their associate membership, which is free of charge if people just want to be part of the society. It's very easy to sign up on the web through www.iusti.org. And my final slide is really just to advertise tomorrow. It's our second IUSD prestigious lecture. The first one was given in Marrakesh last year, but we're delighted that the ISSTDR president, Professor Jeanne Marrazzo, will be giving this particular lecture for us tomorrow morning on the update of vaginal microbiome research. So delighted we're all here. Thank you very much, Jeanne, for all your support. Mauro, again, thank you and the team for putting on what we hope to be a great show. Thanks.
Now I would like to invite the speaker, Dr. Kevin De Kock, for the keynote lecture. Dr. De Kock is director of the U.S. Center for Disease Control and Prevention, Kenya office, and of the CDC Division of Global HIV Kenya. Dr. De Kock previously served as the founding director of the CDC Center for Global Health in Atlanta. He has been on the faculty of medical schools in the United Kingdom, University of London, the United States, University of Southern California, and Kenya, University of Nairobi. From 2006 through 2009, he served as a director of the World Health Organizations and the Department of HIV. He also previously served as the director of the CDC Division of HIV Prevention, Surveillance, and Epidemiology. He has published over 350 articles and book chapters. He is a recipient of the Chalmers Medal, Royal Society of Tropical Medicine and Hygiene, Commandeur de l'Ordre de la Santé Publique, and Officier de l'Ordre National, Côte d'Ivoire, and the CDC William Watson Jr. Medal of Excellence. Now we're going to listen another great music.
Minha alma canta, vejo o Rio de Janeiro, estou morrendo de saudade. E o céu, mar, praia sem fim, e você foi feito pra mim, Cristo Redentor. Braços abertos sob a Guanabara. Esse samba é só porque Rio, eu gosto de você. A morena vai sambar, seu corpo todo balançar. Rios de sal de mar. Dentro de mais um minuto estaremos no Galeão. Rio de Janeiro, Copacabana, Copacabana, Cristo Redentor, braços abertos sob a Guanabara. Esse samba é só porque Rio, eu gosto de você. A morena vai sambar, seu corpo todo balançar. Rio de sol, de céu, de mar. Dentro de mais um minuto estaremos no Galeão. A terra. Viva para. Thank you. Obrigada.
So I would like now to invite Dr. Kevin de Kock for the keynote lecture.
Colleagues, friends, good evening. It's a real privilege to speak to you at this important meeting, and I thank the organizers really very sincerely for the honor of doing this. I address you with some hesitation and a healthy dose of imposter syndrome. That's that syndrome where an external appearance of competence is accompanied by a certain internal feeling of some insecurity. The reason, of course, is that you are experts in sexually transmitted infections, and I am not, and yet here we are. So perhaps this is actually the first paradox to reflect on, that so many colleagues, like myself, devote their professional lives, or much of it, to HIV, which is the world's most important sexually transmitted agent, yet are divorced from the STI community. I could say the same for the UN agency that deals with AIDS, UNAIDS, or in fact WHO's HIV department. Sexually transmitted agents are diverse, but other than HIV, they occupy surprisingly little of current global health space. And one should ask, why and how is this? And as an aside, one has to be struck that physicians talk liberally about sexually transmitted infections, but hardly at all about sex. I suppose for myself, my Jesuit education contributed to that, which I think leads me to my first disclaimer that apart from the Jesuits, I have no disclosures to make. And my comments, I should emphasize, are attributable to myself, not to the Department of Health and Human Services, or CDC. In the next 45 minutes or so, I'd like to give my own perspective on the status and trends in global health before commenting on some trends in sexually transmitted infections. I'll review some recent insights into the sexual transmission of viruses not generally regarded as STIs, and reflect on some major determinants of the future of global health. And I will conclude with commenting on some challenges that I think face the STI community in a global health context. I did get some reassurance to my karma before leaving Kenya on Friday, listening to BBC. First, they highlighted the new WHO report on drug-resistant gonorrhea, which I thought was a good omen. And I will comment more on that later. But secondly, I was also reminded of a Sherlock Holmes story that actually is relevant to our situation. Sherlock Holmes and his friend Dr. Watson went camping, and after a meal and a good bottle of Bordeaux, they fell asleep. And hours later, Holmes woke up. Watson, he asked, "Look at the sky. What do you see?" Watson looked up and said, "I see millions of stars." "What does it tell you?" asked Holmes. And Dr. Watson replied, "Well, astronomically this, and astrologically that, and theologically it means, and meteorologically it's likely to be a fine day." And Holmes, what does it tell you? Sherlock Holmes paused and then said, "Watson, someone's stolen our tent." I want you to reflect on that story as we go through this talk. Globalization features prominently in current political discourse, which, whatever direction it takes, must recognize that our era is characterized by the globalization of public health risk, be it from emerging viruses, sugar-laden drinks, or the movement of people. I'll give a definition of global health and comment on some aspects of health impact and health security. Several documents drove paradigm shifts from tropical medicine and international health to global health. The 1992 report on emerging infections from the US Institute of Medicine warned of microbial threats to health. The World Bank's development report, the World Development Report in '93, saw health as central to development, highlighted the impact of AIDS, tuberculosis, and malaria, particularly in Africa, and stressed the need for cost-effective clinical services. The iconic Durban AIDS Conference in 2000 changed global perception of HIV/AIDS, and then leading to PEPFAR, the President's Malaria Initiative, and the Global Fund, pillars of current global health implementation. Seen through the lenses of development, security, and public health, global health involves all countries, respects local ownership, demands collaboration, addresses all health threats. It's committed to social justice, to human rights, to the environment. From the Millennium Development Goals, 3 of them health-related, we now have turned to the 17 Sustainable Development Goals, which have only one health goal and 169 indicators for all of the SDGs. They speak loftily of ending by 2030 the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, as well as ensuring universal access to sexual and reproductive health services. We should hold development agencies and countries, governments, accountable for eliminating extreme poverty. And this will have spin-off on health, particularly maternal and child health. In terms of health impact, really commendable progress has been made since 1990. We see a halving of global child deaths to approximately 6 million per year, while maternal mortality has reduced, but remains an unacceptable inequity. There are 19 African countries that have maternal mortality ratios greater than 500 per 100,000. Shown in the worst performing countries in the darkest red. Unfinished business includes neonatal mortality, which has hardly reduced. The disease eradication and elimination agendas, such as for polio and measles, need to be completed. We have to hope that we don't see Brown's Law implemented yet again, the law that says that as a disease gets close to eradication or elimination, it's actually the program that frequently is eradicated. And we cannot ignore the contentious issues of inadequate resources for family planning, reproductive health, or deaths of young women from abortion. Health impact for malaria is shown by 37% and 60% reduction, respectively, in incidence and deaths between 2000 and 2015. And the 60% increase in access to insecticide-impregnated bed nets. 83% of cases and deaths, shown in blue, still occur in Africa. Access to malaria diagnostics and its optimal therapy have shown great progress, but there's still much room for improvement and actually lags behind access for HIV services. And drug resistance to artemisinin-based therapy is beginning to emerge and needs to be watched in the Mekong Delta in Southeast Asia. Certain conditions are not just diseases, but markers of social dysfunction, inequity, a society malaise that all is not well. Tuberculosis, cholera, syphilis exemplify that. Really nobody should die from tuberculosis. TB rates fell by 22% between 2000 and 2015, but this annual incidence decline of just 1.5% will not reach the ambitious targets we've set. With an estimated 1.4 million deaths annually, TB is now the world's leading cause of infectious disease mortality, about 400,000 of these deaths being HIV-associated. TB is really more than one disease. In view of its association with HIV and the emerging issue of multi-drug resistance, HIV-associated TB affecting Africa most severely, multi-drug resistant disease worse in South and Southeast Asia and in Eastern Europe. But it is HIV that remains the leading infectious disease challenge, with over 2 million new infections annually, over 1 million deaths, again disproportionate impact in Africa. But really, quite remarkably, over 18 million people living with HIV are now receiving antiretroviral therapy for an estimated global coverage that approaches 50%. And we really should congratulate Brazil for the leading role that it played in increasing access in earlier years. We're living a moment of extraordinary convergence of science, program, and philosophy. A triad of NIH-funded studies, SMART, HPTN 052, and START, showed that immediate and continuous antiretroviral therapy for people with HIV protected individual health and at the same time reduced HIV transmission. UNAIDS advocated for the 1990 initiative, WHO quickly revised guidelines to test and treat, and PEPFAR and the Global Fund support implementation. In parallel, evidence and guidance have emerged on pre-exposure prophylaxis, which protects HIV against HIV, provided there is adherence to treatment. So despite the unique aspects of HIV, its human rights and social essentials, these scientific advances have drawn HIV into the mainstream of infectious disease prevention and control, just like tuberculosis or syphilis, with earliest possible diagnosis and immediate treatment central to the response. And actually some approaches from the STI world, such as partner notification to increase treatment access, are now being adopted. We require science to deliver vaccines for the 3 big diseases, and surprisingly, perhaps, we are furthest along with malaria. The other holy grail in HIV research is the cure. And we search for shorter and simpler therapies for tuberculosis, for multi-drug resistant disease, and different regimens and delivery systems for PrEP, such as long-acting preparations to deliver on these exuberant promises made. And as with any disease where drugs are dispensed on a large scale, resistance is an existential threat. The neglected tropical diseases, classic diseases of poverty, are a collection of diverse parasitic, viral, and bacterial diseases. In the Americas, helminthic infections, Chagas disease, and schistosomiasis remain the most prevalent. To these 17 conditions, somewhat of a ragbag collection, on which it must be said considerable progress has been made, 3 new ones have recently been added. The deep mycoses, ectoparasites such as scabies, and snakebite. Even before the West African epidemic of Ebola, the last few years have seen impressive epidemic activity, including the SARS-like Middle East respiratory syndrome, outbreaks of dengue and chikungunya affecting also this region severely, as well as yellow fever in Angola, the Democratic Republic of Congo, and Brazil. I think MERS would have received much more attention than it has were it not for these other activities, and the recent yellow fever epidemics have posed a great strain on the global vaccine supply. I want to express my empathy and condolences, really, to the people of this region for the tragedy of Zika and its associated outbreak of microcephaly and associated congenital abnormalities. Having grown up in Europe, I'm reminded of the heartbreak of thalidomide babies, and here we have congenital abnormalities that essentially are vector-borne. As of June the 29th, 2017, almost 800,000 autochthonous cases of Zika had been reported from the Americas from 48 countries, with almost 3,500 cases of congenital Zika virus syndrome, and 2/3 of those have been in this country, Brazil. Ebola likely started in Guinea in December 2013. It went on for 2.5 years. It resulted in over 28,000 cases and 11,000 deaths, and it was a signature event in global health. Having been involved particularly in Liberia, I must say this was one of the most extraordinary experiences in my own career. It was Liberia, more than any other country, that changed global perceptions of Ebola from an exotic tropical infection to a risk to global health security. Because of air travel in late July by Patrick Sawyer, a prominent citizen who was visibly ill, flew from Monrovia to Lagos, where he set up a secondary cluster in Nigeria. because of Ebola in American staff working for Samaritan's Purse around the same time, including their lead physician, Kent Brantley, the first infections ever in expatriates, and the first international evacuations to the United States, and Thomas Duncan, who traveled from Monrovia to Dallas while incubating his illness, then infecting 2 nurses before he himself died. Rather incredibly, he presented to Dallas Presbyterian Hospital saying he was from Liberia, that he had fever, and they sent him away with antibiotics for him only to return several days later. In mid-September 2014, President Obama visited CDC in Atlanta and committed to increased assistance, including the deployment of 3,000 troops to Liberia. And the UK military played an important role in Sierra Leone, as did numerous international NGOs who intervened, Médecins Sans Frontières, MSF, the most impactful. And this association between the military, NGOs, and governments was quite unprecedented. Time precludes detailing the experiences and lessons relevant from this experience, such as the time-honored essentials of Ebola control: isolate the sick, safely bury the dead, and follow the contacts, ensuring their isolation or safe burial if necessary. Simple, but a lesson from all of this is that because it's simple doesn't mean it's easy. The unprecedented response included setting up over 24 ETUs, Ebola treatment units, and laboratories capable of Ebola PCR throughout the 3 countries, but these often became operational only after local outbreaks had ceased. And early observations certainly were that we substantially underestimated laboratory and data management needs, that there was universal vulnerability, and there remains universal vulnerability from lack of infection control in healthcare settings. This epidemic curve was drawn after the cessation of transmission. Guinea in blue, it started in Guinea, it finished in Guinea. Liberia, early and brisk, in red, and Sierra Leone, the greatest in yellow, the greatest overall numbers. The relative risk of Ebola in healthcare workers was at least 100 times that in the general population. Healthcare workers accounted for 3 to 5% of all cases, up to 15% early on, most of them becoming infected in the course of their general work outside of Ebola treatment units. Over 500 of them died. Just reflect on that 5,000 of our colleagues from diverse cadres died in the course of this epidemic, in the course of their work. A direct result of the Ebola epidemic has been renewed emphasis on evaluating and strengthening national capacity to meet requirements of the international health regulations that were revised in 2005 after the SARS outbreak. If we turn to recent trends now in selected STIs, there seems a disconnect between aspirational language of official documents and the available data. As called for under the SDGs, WHO speaks of vision, goals, targets to end STIs as a public health problem, and of the human rights aspects, equity, gender equality. But the data suggest that we have a ways to go. The estimates suggest that there are about 357 million cases annually of the 4 curable infections: syphilis, gonorrhea, chlamydia, and trichomonas. 417 million prevalent HSV2 infections, 291 million cases of HPV in women, a persistent burden of syphilis, and 530,000 cases of cervical cancer. In the United States, syphilis incidence has increased almost every year since 2001. During 2014 to 15, it increased by 18% in men and 27% in women. The United States has a screwed up health system, but it has very good surveillance data. The rise of syphilis has been driven, the rise has been driven by syphilis in men, particularly men who have sex with men. In 2015, men accounted for over 90% of all cases of reported syphilis, And of those men with information available, 82% were MSM. And on this slide, the dotted line at the top shows the male-female ratio increasing over time. The dark line below, the case rate per 100,000 in men. The lower dotted line, the total incidence rate. The bottom solid line, the incidence in women. Syphilis epitomizes health disparities, its incidence in African American males and females being 5 and 9 times greater, respectively, than in whites. On this slide, the absolute numbers of cases of syphilis are shown by HIV status for 31 states with information, negative dark blue, positive light blue. For men who have sex with women, on the left, women in the middle, and MSM on the right. 50% of men with 50% of MSM with syphilis were co-infected with HIV, as opposed to 10% and 4% of heterosexual men and women, respectively. This trend for increased incidence of syphilis among MSM is substantiated in different trend studies in the United States on the left, as well as in Europe on the right. Men who have sex with men also account for a disproportionate and increasing fraction of cases of gonorrhea. And here you see the proportion of urethral isolates obtained from MSM in a CDC gonococcal isolate surveillance project. With an increased incidence of syphilis in women in the US, congenital syphilis has increased, shown in the histograms, by 35% since 2013. In 2015, there were 487 cases of congenital syphilis reported, which is more than 4 times the number of reported HIV infections in children under 13 that year. An important trend is increased gonococcal antimicrobial resistance. On the right-hand side of the slide in dark blue are the sensitive the proportion of sensitive isolates. Approximately 40% of isolates have some resistance, with approximately 6% showing resistance to penicillin, tetracycline, and the quinolones. The results of WHO's gonococcal antimicrobial surveillance project that I mentioned earlier have just been published in PLOS Medicine, highlighting persistent resistance to penicillin, tetracycline, and ciprofloxacin, increasing resistance to azithromycin, and emerging reduced susceptibility or resistance in extended spectrum cephalosporins. But note the large areas shown white on the slide, particularly in Africa, from which no data are available. A public health emergency with implications for STI spread is the epidemic of opioid abuse that has crept up on the United States, linked to prescription analgesic use as well as heroin and other drug injection. Overdose deaths in the United States now exceed peak mortality ever from HIV, gun violence, or motor vehicle crashes. An outbreak of HIV involving 181 case patients was recently identified in a predominantly white rural county in Indiana. 88% of case patients injected opioids. 92% of case patients were co-infected with hepatitis C, and 3% had a positive plasma reagent test. A quarter of the female case patients exchanged sex for money or drugs. With recent events in West Africa and the Americas, we've gained new insights into sexual transmission of viruses and their viral reservoirs. King Holmes's classic textbook on STI categorizes pathogens according to whether they are predominantly transmitted by sex between adults, sexually transmissible but not predominantly transmitted by sexual intercourse, or transmitted during sex contact but by fecal-oral exposure. 3 pathogens clearly sexually transmissible but not primarily transmitted that way are Ebola, Zika, and hepatitis C. We do not know the real frequency of sexual transmission of these agents because such cases are usually hidden amongst the mass of regular transmissions during an epidemic. In March of 2015, Liberia seemed on the way to being declared Ebola-free when a woman presented with and then died from Ebola with no source of her infection that we were able to determine. However, a sex partner with whom she'd had intercourse 1 week before her illness onset was an Ebola survivor who was subsequently shown to be PCR positive on semen 199 days after the onset of his own illness. Sequencing of genetic material from both partners showed common mutations. A study from Sierra Leone examining semen specimens from 93 survivors showed approximately 1/2 overall were positive for Ebola on PCR, the relative proportions declining from 100% at 2 to 3 months to 65% at 4 to 6 months, 26% 7 to 9 months. A modeling exercise from Guinea described a median of 46 days persistence on the left of the slide, but there's great heterogeneity. And a single case report from Liberia on the right described an HIV-positive survivor on antiretroviral therapy whose semen remained PCR positive at 565 days. Approximately 1/2 of Ebola survivors complained of persistent symptoms, mainly arthralgias, with 1/4 expressing visual symptoms, the most serious due to uveitis with viral persistence. And I was struck by the stigma, discrimination, and social impact from Ebola, which was surprisingly reminiscent to me of that associated with HIV. Concerning Zika, sexual transmission has been documented from male to female, female to male, and male to male. A study from Puerto Rico of 55 men showed median RNA persistence of 34 days, the longest 125 days, with 95% estimated to be undetectable by 81 days. Global health is global, but Africa exerts disproportionate influence because of the disproportionate burden of disease and likely future trends. Economic growth, security and conflict, migration, corruption, environmental and climate change, use of natural resources, and above all, population growth will all have their effects, not only on Africa, but also on the rest of the world. I should mention that, particularly worth mentioning, but for lack of time, not in any detail, the issue of migration. Just this year alone, over 2,000 people, over 2,000 Africans have drowned in the Mediterranean trying to cross from Libya to Italy. Last year, over 5,000. The whole effect of migration, I think, is grossly underestimated politically as well as medically. And also underestimated is the effect of population growth, which will mean that by the end of this century, Africa will account for 39% of world population, and 80% or so of youth in the world will actually be Africans. Universal health coverage to prevent impoverishment from catastrophic healthcare costs dominates discussion everywhere. And even as we face continued infectious disease challenges, the emerging non-communicable disease epidemic is evident. Antimicrobial resistance is an international threat, and the health effects of climate change, perhaps the greatest unknown. In fiscal year 15, the US Congress approved an emergency allocation of $5.4 billion for Ebola, of which $3.7 billion was for international activities. Future trends in funding for global health programs are uncertain. Currently, about half of global health funding is provided by the United States. I think what is certain is an increasing expectation from development partners for accountability around the use of resources, for greater investment in health from domestic resources in all countries, and for committed action on corruption. So I have reviewed trends in global health, aspects of sexually transmitted infections, and anticipated forces influencing the global future. If I've paid inadequate attention to the Americas outside of the United States, it's for lack of direct experience. I apologize, and I recognize that, like politics, all public health ultimately is local. I want to finish with some personal and therefore subjective comments on your technical area and community, which I fear face some existential threats that need to be addressed if we are to see progress in STI control in the world. Suggested headings for some of these comments include science and program, data, visibility, funding, advocacy, communication, and networks. And it's perhaps in relation to this final part of my talk that the story of Sherlock Holmes and his tent is relevant. My CDC colleague, John O'Merman, summarized the challenge starkly for the United States. He said, "We've reached a decisive moment. STD rates are rising, and many of the country's systems have eroded. We must mobilize, rebuild, expand, or the human and economic burden will continue to grow." And that's the United States. I see many analogies with tuberculosis over the past 40 years, and I should acknowledge there's been tremendous progress and change in tuberculosis and in the tuberculosis community. Dr. Jim Mason, then CDC director, spoke at a national TB conference in 1984. Instead of the usual endorsement of the status quo, he challenged the public health community and pushed them to aim higher. He observed that sputum microscopy and tuberculin skin testing, mainstays of TB diagnosis, were tools from the late 19th or early 20th century. The drugs were decades old, some with side effects. Consider this comment from Lee Reichman. Here we are in 1992 with cure rates lower than countries like Malawi and Nicaragua. We can't keep track of our patients, and all the evidence suggests more and more of them have resistance to our best drugs. We've turned a disease that was completely preventable and curable into one that is neither. We should be ashamed. He was talking about TB, but could this apply to gonorrhea? We pride ourselves that medicine is an art as well as a science. In reality, we emphasize art when science is weak. And I think diagnosing syphilis illustrates this. Dark field microscopy was introduced by Landsteiner in 1905, the first serologic test by Wassermann in 1910, the first specific test for Treponema pallidum in 1949. The man there actually is not any of those, it's actually the great Robert Koch from tuberculosis fame. Regular practitioners don't understand the art of interpreting syphilis serology. And newer diagnostics, such as enzyme immunoassay or PCR, are neither standardized nor widely available. We managed to push modern molecular diagnostics for Ebola to the remotest parts of West Africa, but we rely on decades-old approaches for major STIs, even in high-income countries. We have deployed the GeneXpert technology for TB, able to be extended to HIV viral load testing widely in Africa. STI diagnosis does not feature highly in the agenda for development of point-of-care diagnostics. An exciting scientific advance is the introduction of real-time molecular analysis, including sometimes whole genome sequencing, of different infectious agents in their transmission networks, including HIV, hepatitis C, foodborne agents, and recently Ebola, giving insight into who is infecting who and facilitating targeted interventions. This paper from Jades describes US experience applying molecular techniques to surveillance specimens. I have not seen this applied widely in STIs. One of the reasons for success of PEPFAR, the President's Emergency Plan for AIDS Relief, is its sharp focus on accountability, performance against targets, real-time use of data, for modifying the program. But for all of that, you need reliable data. Former CDC AIDS Director Jim Curran said that surveillance is the conscience of any epidemic. Former WHO Director Margaret Chan is on record as saying that what gets measured gets done. Funding decisions and specific disease allocations have to be based on epidemiologic data and prioritization. For HIV, robust calls for specific funding amounts are based on detailed epidemiologic data and defendable estimates. Data on global STI rates are woefully inadequate, and what doesn't get measured cannot attract funding. But it's not only about data, and it's not only about funding, and we need both politics and advocacy. Despite all of that, looking at NIH funding for disease-specific research, STI allocations are actually greater than I had expected. They're commensurate with those for malaria and tuberculosis, although they're tenfold less than for HIV. The numbers on these slides are in thousands. HIV receiving, yes, tenfold more than STIs. More visible and focused discussion on STI research prioritization would be useful, and I certainly would advocate strongly for greater pressure for vaccine development, including and especially for HSV2 and for gonorrhea. I think the STI community needs to reconcile its ambiguous relationship with the global HIV movement. One could argue it should be the other way around, but I don't think that's going to happen. I think it needs to reconcile the ambiguous relationship with the global HIV movement, with which initial convergence of agendas appear to have been lost. Early convergence of interests in the early 1980s resulted from evident sexual transmission of the AIDS agent, identification of key populations at risk for HIV and STI, a strong association between genital ulcer disease and the acquisition and transmission of HIV, demonstration of increased shedding of HIV with diverse STIs, and then later the results of the Mwanza study. Published in the mid-90s in The Lancet, the Mwanza study suggested an approximate 40% reduction, you'll remember, in HIV transmission following control of curable STIs. The forces of divergence, however, seem to have been stronger. The AIDS field attracted the interest of diverse disciplines and professionals not steeped in STI science. Many focused on non-sexual transmission of the virus and its prevention, or on the general manifestations of HIV disease. Unprecedented political, social, and financial advocacy arose, so that HIV was treated differently from other infectious diseases, referred to as AIDS exceptionalism. And scientific advances then drove a programmatic response. The Rakai study failed to replicate the Mwanza findings. Treatment of HSV2, a risk factor, did not reduce HIV transmission. And then a panoply of studies clarified HIV prevention interventions, including antiretroviral therapy itself, male circumcision, PrEP, and the prevention of mother-to-child transmission. And of course, immediate antiretroviral therapy is now central to the global AIDS response. Most unusual has been AIDS advocacy, more effective than for any other disease. Activists influenced political leaders and agencies such as the NIH and the FDA. Community support groups sprung up. HIV in famous people such as Rock Hudson, the actor, the dancer Rudolf Nureyev, or basketball legend Magic Johnson increased visibility. Foundations such as the American Foundation for AIDS Research attracted support from Hollywood figures such as Elizabeth Taylor. In the UK, Princess Diana was a patron of AIDS organizations, visited HIV patients in hospitals. We don't have that for syphilis and STIs, and regrettably what often comes to mind is earlier unethical research, such as the deplorable studies in Tuskegee or Guatemala. And perhaps nothing illustrates any of this better than this tale of two diseases, than a comparison of congenital syphilis and mother-to-child transmission of HIV. There are approximately 150,000 new global HIV infections in children annually, compared with an estimated 350,000 adverse pregnancy outcomes from maternal syphilis. I have no idea about the validity of the syphilis estimates. I think those for HIV are reasonable. The story of Elizabeth Glaser is an inspiring one. A Hollywood personality, she contracted HIV in 1981 from a blood transfusion at delivery, and she then transmitted HIV postnatally to her daughter and to a later born son. And when her daughter Ariel died in 1998, she determined that the same would not happen to her younger son, and she established the Pediatric AIDS Foundation, which was renamed after her when she herself died of AIDS in 1994. Today, EGPAF is a major HIV/AIDS program implementer. Alas, there is no foundation for the infant with congenital syphilis. So, where do you go from here? Dixie Snyder of CDC said a long time ago about tuberculosis that if you keep doing what you've always done, you'll get what you always got. The great Darwin said that it is not the most intelligent of the species that survives, but the most adaptable to change. So I think the answer has to lie in the community, and it is from within the STI community and its partners, its constituents, and its beneficiaries that the necessary leadership and activism have to emanate. But I do believe that there are important lessons from HIV and tuberculosis. The educator Geoffrey Canada poignantly wrote of his realization of the inevitability of self-reliance. One of the saddest days of my life, he said, was when my mother told me that Superman did not exist. Even in the depths of the ghetto, you just thought, he's coming. He always shows up and saves all of the good people. And I was crying, not because Superman wasn't real like Santa Claus, but because there was no one coming with enough power to save us. As a finish, I'd like to thank John O'Merman and John Brooks from CDC for helpful discussion, Julie Mwabe in Nairobi for assistance. I think some inevitable conclusions are the need to forge alliances, to participate in broader agendas, to infiltrate networks and increase visibility. Linking the STI agenda to emerging scientific and global health priorities, such as antimicrobial resistance, research on the microbiome, molecular epidemiology, and vaccine development, all deserve more thought. Like rights, authority and influence are more often taken than granted. With all that the world has at its disposal in 2017, it surely is not right that syphilis, as important historically as tuberculosis, still flourishes and lags so far behind programmatically in global health, and that STIs in general feature so little in maternal and child health. We need stronger science, for sure, better technology, deeper epidemiology, but none of those will save us. In the final analysis, it always comes down to people, their relationships, their networks, and their leadership. Leadership meaning the ability to get others to do what needs to be done. With the humility of an imposter, I thank you for your attention. I wish you success in this meeting and your future work. Thank you.
Thank you, Dr. Kevin de Kock, for this wonderful keynote lecture and presentation. Well, the committee, the scientific committee, our chairs, and the president, we would like to invite to the welcome reception at the ground floor. And we are finished.